The House Oversight Subcommittee on Public Health and Food Security will come to order. Would the clerk please take the attendance?
Chair Bearline.
Here.
Representatives Paquette, Green,
Present.
McDonald,
Present.
Cerniglu.
Here.
Mr. Chair, you have a quorum.
Representative Green moves to approve the minutes of the April 15th, 2025 meeting. Hearing no objection, they are approved. Good afternoon. Today we're taking a closer look at the Michigan Public Health Institute, an organization that plays a significant role in delivering public health programs across our state. As MPHI continues to partner with government agencies and manage large amounts of public funding, it's important that we understand its structure, scope, and accountability to both the legislature and the public. We're pleased to welcome a key leader in that conversation. Dr. Renée Branch Canady is the CEO of MPHI and a longtime public health leader, former health officer for Ingham County. So, Dr. Canady, thank you for being here, and we look forward to your insight. Please.
Thank you. I appreciate the invitation and the greeting and the context. Representative Bearline, thank you for your comments. So I wanted to just give you maybe some contextualizing comments to open and then defer to questions and thoughts that you might have for me. So I was thinking about first the context of this work, and there is a definition that says public health is what we as a society do together, do collectively, to assure the conditions in which all people can be healthy. And something about that purpose resonated with my own personal purpose, doing what I can do to make sure the people around me are healthy and wealthy and happy and prospering in many, many ways. And my colleague, Dr. Georges Benjamin, who's the executive director of the American Public Health Association, always reminds us, public health is a team sport. And so it is what we collectively do, what you all are doing and what I have the privilege to do at MPHI. I have had this very amazing career in that I have practiced public health at local government, as Representative Bearline said, leading the Ingham County Health Department. I've practiced public health in the academic setting as an assistant professor at Michigan State University in their program for public health, their CS Mott School of Public Health. I've done work as a civil servant in the state of Michigan, and now sit in this really unique setting of nonprofit partners in public health. Completely different from what I ever understood public health partners to be. And so I'm really honored to be a part of the team. I wanted to share another bit of context because as particularly during these last 5 years, people have asked me often, what exactly is public health? And so I was thinking about an easy way to help everyone understand that. And I thought about the work of Dr. John Snow, 1800s, early physician in London. And he is considered the founder of epidemiology. He was also a physician, though, and there was a period during what became the cholera pandemic in the UK where he was in his exam room treating patients. Here comes another patient, treat them. Here comes another patient, treat them. And he started noticing, why are all these people coming in with the same symptom profile? So instead of just treating people one at a time, he decided to go out into the community, start knocking on doors, similar to what many of you probably did to get these jobs, talking to folk, asking them what are the concerns, what's happening, and finally found this common denominator of a water source called the Broad Street Pump. And he could have just said, oh, you guys don't drink from that water pump. But he then went to the elected body in London to say there's a system, a structure issue. Everything that he did outside of the four walls of his exam room is public health, was public health. What he did in the exam room is healthcare, primary care. And so the two fields are deeply related, healthcare and public health, but most people, when they hear public health, are thinking my doctor in the clinic. So I think it's always helpful to contextualize that to help you also see why MPHI is involved in some of the things that we're involved in. I would offer to you that MPHI is not what I would call a typical vendor. We were actually created by the legislature in partnership with the Department of Public Health at the time to extend their capacity to advance the likelihood that Michiganders would be healthy and well. And so we are one of about 51 public health institutes across the nation, but I would say we are the only one that is a demonstration of governmental innovation. We are unique from any other public health institute, many of which are academic, and although we are a governmental academic partnership, the depth of relationship that the legislature subscribed both for accountability and transparency, I think is a unique part of our partnership with the state. I am a person who loves quotes, and so I'll close my opening remarks and defer to your questions with a quote that I love from Dr. Martin Luther King. And he says, "I have the audacity to believe that peoples everywhere can have 3 meals a day for their body, education and culture for their minds, and dignity, equality, and freedom for their spirits." That is really what public health is. And I, like Dr. King, also have the audacity to believe that Michiganders can be the healthiest, that what we do in Michigan can be a model not only for the Midwest, but for the nation. We've seen change happen. We've seen improvement and thrive in the face of barriers and difference and dissension. We have found a way to pull together for the health and well-being of Michiganders, and it is my honor to have served this state and this community all 30-plus years of my public health career. So thank you for the opportunity to brag a bit about my state and the innovative decision-making of this legislature.
Thank you for your remarks. I know I have some questions. I don't know if anybody else will come up with some questions as we're going. I can start with Rep. Green. Rep. Green?
Thank you so much, Dr. Branch Canady, for coming today. When did you start working for MEHI? What year?
I started working in 2014.
Okay. That's my first question. And I'll wait to see what the chair says before I ask any more questions. But I just needed some context. Thank you.
I guess my first question, I'm trying to understand the relationship between MPHI and DHHS. And so is it, I understand that there's statute that created MPHI to work with, is it a bridge between research universities and the department, or is that, am I summing that up correctly?
That's an accurate assessment. I would say that there was intention to bring together the sort of 3 flagship universities at the time. So Michigan State University, Wayne State University, and the University of Michigan are equal partners on the board of directors with the state of Michigan. So where could we bring all that capacity, all those resources, the think tanks together in a non-competitive space that would work to advance the health of of Michiganders? Okay.
I know that Director Hertel is still the president of the board. Mm-hmm. How does that relationship work? Because I'm trying to think of the best way to phrase it. She's the chair of the board and director of the department, but the department is subcontracting sometimes with the MPHI, and so is there any kind of conflict there? You mentioned the board and how that's made up, and I'm just kind of curious as to how that works.
Yeah. No, I understand the question because it seems like, but for the fact that it was intentional. If the state was going to have sort of a trusted partner that they created that was at arm's distance, right? So it's not the state, and that was intentional because MPHI can pursue a variety of funding sources that the state can't pursue. So there was an intentionality about having distance but having closeness. Because it is a major partner, the accountability needed to be very, very high. The transparency needed to be very, very high. And so it's like, here's our sub-entity helping expand our capacity, and the accountability comes because the director is the chair. Now, sometimes the director delegates the chairship or the presidency of MPHI to one of their staff, but it was intentional about being able to guide the mission, the vision, and the purpose of this new organization.
So is that, is that position then kind of set up, it's not really, it doesn't have to be Director Hertel, it's really MDHHS is the chair of the board?
No, it is, in our bylaws, the director of MDHHS is the chair or their designee.
Or their
So
designee.
Director
Okay.
Hertel could identify anyone on her staff if she chose.
You mentioned you're able to go after funding sources that maybe the state wouldn't be able to. Can you explain that? How does that work, or what are those funding sources?
Well, they're pretty variable. Sometimes philanthropy will have grant opportunities that are specifically not for governmental entities. So it really just depends. We have philanthropic dollars, we have contracts, we have federal dollars, other partnerships with universities, even NIH dollars. And so it really depends on that individual opportunity and what the guidelines are associated.
Okay. Any other questions yet?
You ready?
I mean, please.
Oh, here, let
Oh.
Representative McDonald go. She'll go.
Representative McDonald.
Mine are just way off this line.
Well, whatever questions are fair game. Please.
Change the narrative. Okay, here, there, now I can do it. Over the past several weeks, we've seen a reduction in federal health funding and support. Can you speak to what impact the federal cuts might have on MPHI's work in Michigan, if any?
Certainly, there is and will be impact to MPHI. Our budget is about 55% federal dollars. Some of that is directly awarded to MPHI in our own contracts. Others of that is indirectly through the state, so through MDHHS. So as you can imagine, the significant cuts to the Centers for Disease Control did trickle down to us. And so at this point, we're trying to approach those reductions in a way that mediates the impact to direct services, working with the department to see if we can put folk on other funding sources, or is there a workforce need in another project? Is there a civil service opportunity that we can transition them to so that the work continues? So yes, we're anticipating the other thing that I'm having my team do to try to mediate losses is to quite candidly look for other funding sources that can be stop gaps for the losses here, again, so that the services to the residents of Michigan continue. Thank you.
Thank you, Chair. I had a question in a similar vein. Recently, I was at a very lighthearted event with the Oakland County Executive, and I asked him how it was going, and he told me that not so well because of these kinds of cuts in funding. He told me about 2 Oakland County programs that were about disease surveillance and preventing infections in long-term care facilities had been cut by $3.7 million, funding that was supposed to continue through September, which means it's prior year authorized. I don't know if anything sounds more like a public health issue than trying to keep our long-term care facilities healthy. Can you talk a little bit about what that kind of cut means? And is there a way to find funding for a program that was just stopped dead and was supposed to go through September?
I do think, thank you, Representative McDonald. I think that the challenges are the timing with which the grant and the contract terminations are occurring. Yes, significant losses, not only to elderly, but to all of the population. I'm happy to share some of the projects that we engage in. In this country, the model for public health is governmental. The vast preponderance of investment is through in governmental sectors, either at the federal level, the state level, or the local level. And so those losses then have direct impact on the constituents that they're established to serve. We are still in the midst of sorting out what the impact will be. It's still a little early on, first quarter of the year, but we definitely see the impact to a variety of folk, whether it's maternal child health projects, as you said, geriatric, elderly, adolescents. So we're just trying to figure out how to roll with the punches, as they say.
I want to go back to the relationship with DHHS. You said about half of your employees are working with DHHS or through MDHHS. Are any of them, are they part-time? I guess I'm just trying to, is it basically like I've been a contractor before where I worked at a company, but I worked for somebody else, but I was 100% dedicated to a job at that company. Is that relationship, or are they part-time working for you, part-time working for DHHS? What does that look like?
Yes, just to clarify, I was offering that 55% of our budget is federal dollars, some of that MDHHS. We do have a significant portion of staff that we refer to as affiliate staff, in which case, as I think I mentioned, that they are employees of MPHI, but they are assigned to the state. And so they serve as staff to MDHHS. They work exclusively for the department. They get their direction, their marching orders, if you would, from the department. And so it's not sort of a back and forth. They're focused. And as with any workforce, if the department needs a part-time staff, we would hire a part-time staff if that's their desire. If it's full-time, it would be full-time. So all dependent upon the needs of the program.
Do those employees assigned to the department, do they meet, I guess, kind of our state hiring standards? We're going to pay them what we pay state employees. They're going to get the kind of benefits state employees get, retirement options, those kinds of things. How does that look?
Absolutely. We work very, very closely with the department's HR leader, as well as working closely with civil service in terms of making sure there's some comparability, right? We just, as you know, the state gave a significant pay increase to civil servants. We endeavored to mirror that as directed by the department to do so that there is salary equity across affiliates and civil servant staff.
And before I let somebody else ask some questions, can you estimate about how many of your employees are in that kind of affiliate status?
I can estimate, and
tell me the real number.
I know. I'm like, I should have pulled the exact number, and I did not pull it. We have about, I'm going to broadly guess, and I will get you the precise numbers, Representative, about 350 to 400 what we call Okemos campus, simply because that's where our office is related, that are sort of MPHI proper, and about, right now, 600 folk that are affiliate staff assigned to the department. And I will get those precise numbers to you.
Thank you. Rep. Cerniglu, you had more?
Sure, thank you. Sounds like the statute creating MPHI was enacted over 30 years ago, and the state has had a long-standing relationship with MPHI, spanning the administration of 5 governors from both sides of the aisle, several department directors and legislatures. And given the evolution of MPHI and your experience as CEO, are there any statutory changes that you would recommend for the legislature to consider regarding MPHI?
Thank you, Rep. Cerniglou. You know, I marvel at how adaptive the model has been. It has just served every generation and every decade and the changing needs of public health, from HIV to H1N1 to COVID. The model has been adaptable. It's really just innovatively brilliant, I think, on behalf of the civil servants and leaders who created it in partnership with the legislature. There is not any recommendation for statutory adjustment that I would make at this time.
In the last few years, like in 2021, for instance, there was a state hiring freeze for civil servants. Because so many of your employees work for DHHS, would you have been subject to that? Or I guess as DHHS wasn't able to hire more employees, were they able to just bring on more contractors or affiliate staff?
Well, no, because we serve in what I describe as a cost reimbursement model. We're not making money, we're spending money as allocated to us. And so if the state does not have money allocated to hire, then we would not be hiring on their behalf.
Okay, thank you for that. I know Rep. Green had questions and she had to step out for. Yeah, Rep. Cerniglou, please.
Thank you. I wasn't here for the presentation, but it's my understanding that MPHI presented in health policy last session on the social detriments of health. What more do you think we can do as a state to advance health equity? And are there any best practices we can employ in Michigan?
Ooh, that's a whole lecture series, Representative. I do think we are sort of socialized to think about health at an individual level. And individual behaviors and choices, if I dare say, are important. But what is equally important is the context of health and wellness. If we want people to walk more, do our Michigan neighborhoods have safe streets and safe sidewalks? Those are infrastructure questions. And so we sometimes describe public health as where we work, where we play, where we pray. It is the context of our lives, and does it allow us to live those lives in ways that are healthy? Is the air clean? Is the water safe? Is the food safe? So those large systemic changes. And I do think there are some things in our state that make it difficult for particular areas of our state, more so than others. And being able to look at what is needed. We sometimes say treat everyone the same, but we argue in public health that we should treat people based on what they need. So there are a number of things. I'd be happy to share some thoughts in writing about opportunities for health improvement for Michiganders.
Would you be willing to hang around for maybe 10 minutes? Well, I know Rep. Green had some questions she wanted to ask, and she had to go testify in another committee.
No problem at all. Absolutely.
Okay. Committee is going to Eddie's. The committee will come back to order. Representative Green has some questions.
Thank you so much. Again, thank you, Dr. Branch Canady. I have some questions about, because I'm trying to understand what y'all do. And how I looked in the code, it's that it was created quasi under DHHS as a non-government organization. And the purpose was for university research and advancement in public health. So my question is can you tell me about your relationship with the universities? Like what studies you are involved in right now? Do they give you any funding to help coordinate this? How much money have you pulled in from grants federally or grants globally to be able to fund the university relationship?
Thank you, and thank you for taking care of multiple things at one time today. So the partnership was orchestrated, if I can use that word, to build relationship both across universities and then with the universities and the state. And so it really varies. Some universities we have no partner projects with at the time. Others we're co-submitting on a variety of grants and contract opportunities. I would actually, I don't think I have on my list specifically projects that are with the universities themselves, but I can certainly run our data and get that specifically for you. So NIH dollars, foundation dollars, again, it depends on the opportunities and the requests for proposals that we would pursue together. Sometimes the universities are primary and we're sub with them. Other times we are primary and they are sub with us.
When you say that, are you actually conducting the studies or are the universities conducting the studies?
Typically, it's the university. We bring capacity, right? We're the capacity
What does that mean,
extenders.
capacity?
Meaning, instead of the university having to hire a large research team, that we could bring evaluators, project managers, statisticians, or whatever would be called for the project. So we would help comprise the team.
Okay, so what is the biggest project you have right now?
Oh, honestly, Representative, I would have to go back and look at that in terms of size.
Okay, just name one project that you have right now with the universities.
Let's see here. You know, I actually focused on the work we had with MDHHS in the list that I pulled together. So as I look through my list, like I said, I can run a report of the specific
Okay, wait.
projects.
I just want to be clear. So,
Yeah.
What is your role with this organization again?
I'm the CEO.
Okay, and in our code, and I'm trying to be calm. Like, so are there any projects going on with universities right now?
There are.
Okay. But as the CEO, you cannot name one right now.
We have a large portfolio of work. Okay. And so presently, no, I am not. Maybe it's nerves.
Okay,
Maybe
that's why I'm trying. I
to,
understand.
yeah.
I was just in that hot seat myself for the last 20 minutes, so I'm trying, but I'm also trying to figure out exactly what you do. Okay, so if you can't, then you don't know the university is there a project that you're working on in DHHS right now?
There are a number of projects that we're working on. We do a number of work around.
Can you identify one?
Yes, I'm preparing to list off some of those for you, Representative. One of our largest projects is our child death review work.
Say that again.
Child death review.
Child death?
Mm-hmm. There's also our overdose fatality review work that we do with the department, the opioid task force work. There's epilepsy control. If you think about most aspects of health and public health, and as I said, I'm happy to provide the list to you. ACEs, which is Adverse Childhood Events, a very important model that came out of the Centers for Disease Control. We're part of the Michigan ACEs work. There's perinatal regional collaboratives looking at pregnancy experiences. Senior Fresh, Project Fresh, working with seniors. So I'm happy to get you a more comprehensive list of the numerous projects. If you think about the variety of work that MDHHS oversees, as well as public health priorities for our state and that our universities are engaged in, those would fall under our qualifications for contributing to.
So when the original law was made, it was to focus on getting ahead of like infectious diseases. When did it pivot towards just kind of general health issues?
I have not understood it, and I've been in my tenure for 10 years, I've not understood it to be focused on infectious diseases. That is one critically important component of public health, but not the exhaustive list of why public health and Michigan Public Health was created. It was really a broader sort of branch to support, to bring additional funding, to help with staffing, to help with evaluation. And so the broad span of responsibilities for public health in that line, that sentence that says advancing the health and public health is where we've landed. So it's been a very adaptive model, depending on what the priorities were that were happening, what were the needs happening in the department at the time. So very responsive.
Okay. A budget question would be, can I keep going? I don't know what you're letting me. I mean, well, I'm trying to learn about this and trying to learn the role. So with how much of your funding comes from the state versus how, and if you guys asked that question, versus how much of your funding comes from outside sources, do you have a percentage?
We do. I do have a percentage, and I appreciate your questions very much. So presently, our program budget is about 0.5% of MDHHS's budget. In Michigan Public Health Institute's overall budget, we're at about 86% of our dollars coming from MDHHS. Now, I will offer that coming in as a new person, I wanted to see a little more variety in our funding portfolio, quite candidly, to limit the burden to the department. So when I looked over the last 5 years, we were at one point around 93% of our dollars coming from MDHHS. You'll see that tapering down to where we're now at 86, and that continues to be a priority for me as the leader of this organization.
Okay. Yep.
I just want to clarify, just because I didn't write things down fast enough. So 86% of your budget's coming through MDHHS, but then about half of that are federal dollars, half are state dollars. Of that 86%, is that close?
In our overall budget, if I look at
Okay.
how much of that is sourced from federal funding opportunities, it's 55%.
Okay.
Some of that coming directly to MDHHS with our own relationships with CDC and
Okay.
HHS, and then others of it coming indirectly through MDHHS.
Okay, that clarifies.
Okay.
And then you had mentioned the percentage of the budget, the percentage of the MDHHS budget that is MPHI. Well,
It is, yes, it's less than 1%, half, 0.5. Mm-hmm.
okay. Rep. Cerniglu?
Thank you. A couple, just, I guess, kind of questions, maybe comments. It looks like you actually do have to submit like a report on everything you do and all of how much it costs. And I think it was like 42 pages, the previous one. Is that accurate?
It is a very comprehensive report of our deliverables for every project that we touch on behalf of the department.
And just quickly searching for maybe what things you're doing with universities. I don't know if this is something you're doing now, but I do see some things about well-being assessments with MSU and lots of other work you're doing with MSU.
Yes, community health assessments are a large part of our portfolio. We were really honored. Michigan State just did a large expanse in their health and well-being division, and we had a large role in supporting them with that.
Thank you.
Thank you for that reminder, Representative.
Where can, I don't care who answers. Where can we find that deliverables report?
We have transitioned that to an electronic version because it was getting pretty copious. I can make sure that we get the link to that report to you.
Okay. Thank you.
The
Representative.
report, for the record, I'm sorry, it goes to the department, and the department then provides it to you.
Thank you. Representative Green?
So another hat that I wear is I'm the chair of communications and technology. And so something that always fascinated me, and I hope you can answer this question, but it was, did you conduct the contact tracing during COVID?
We facilitated contracts on behalf of Michigan Department of Health and Human Services, yes.
And then who were those contracts then? If you facilitated, who was awarded those contracts?
I actually don't have the list. I can get the vendors to you.
Okay.
The department, our role in that process was, I would describe as transactional as opposed to decisional. So the department made the determinations of how to distribute the funding, with whom to partner. When their process was completed, in cases it would come to us and say, stand up a contract with X vendor. We do due diligence around that, looking at disbarment or any other reasons to not contract with those individuals, implement the contract until asked to do otherwise.
And then, I get. Were you then asked not to do that anymore?
No. We did have one contract where the contract was stopped with the vendor, and so when we were informed to stop work with that vendor, as in any of, not just contact tracing, but with any contract, if for whatever reason the department decides we're not going to continue with that vendor, then we receive a stop work order from the state and then execute with the.
Does the department, the state, tell you why, or do you ask why, or do you just do what you're told?
We typically follow their requests. In that role, we are not a decisional partner. We are a transactional partner.
And the reason I asked that is because I was curious how, because data privacy is something really important to me.
Absolutely.
And how those were vetted. To make sure that, because you were sharing locations, there's a lot of tracking, stalkers do some crazy stuff, and so I just was curious as how well vetted that was for security breaches, and if you had that role to investigate that on what the contracts were, or if it was just DHHS that did that for you.
In those cases, I would have to defer to the department for what their specific practices were. Certainly, as a former health officer, I have a deep appreciation for confidentiality and security across contact tracing as a public health practice. It was not our role to make decisions in that regard, but to simply execute.
Okay. One more question.
nope.
Okay.
I'm
thanks.
going to go. I'll come back to you.
No, it's okay.
I just don't want to forget. So you mentioned you were kind of the payer for those contracts, but the guidance all came from DHHS, and they determined if you would enter into or exit one of those contracts. So why have you be the payer for that? Why go through you to do that contract if they're making all of the determination for who's going to get the contracts?
In some cases, and again, I didn't ask, why are you asking us to do this? But my assumptions would be around volume, workload, sort of sectoring groups in particular areas so that they could focus on this particular area of work. So a variety of things that might influence that, which I would, again, defer to the department to delineate.
Thank you. Representative Green.
Just one more question, that with the COVID funding, do you still get COVID funding at all? Did you get COVID funding?
We did. We got some COVID funding directly, and again, COVID funding through the department. Yes, as you know, that the COVID dollars are trickling down, sunsetting, I guess I would say. And so we do still have some of those dollars that are transitioning.
Thank you.
Anyone else? I have just one more question, and I think, unless that brings up follow-ups, and I hate to keep going back to funding, but We always care about funding. So you've been transitioning, I don't want to say away from governmental dollars, because you're not, but you are trying to get more outside sources. What are those outside sources? You did mention some philanthropy, but are there others?
There are others. In some regards, we perform almost like a consulting firm. And so some of it might be with other states. We're doing some work with Indiana. We do a large amount of tribal work with a variety of states. So some of it would be, as I said, in sort of that consulting role, who needs some assistance. A variety of philanthropic organizations, Robert Wood Johnson Foundation, the Kellogg Foundation, the Ford Foundation, and so different priorities there. Some of our contracts come directly from local health departments. They would subcontract with us or pay us to support them in whatever space. So it's a fairly big braid of resources that we blend together for our fiscal model.
Okay. So on your website, you have a dashboard that kind of has some highlights, publications, presentations, things like that. And on there was an item of over 150 presentations at conferences and things like. Is that a funding source, presenting, or is it not included in that?
Typically, these are academic and professional conferences that are not payment sources, but an opportunity for us to, I think, be good stewards of the information that we're learning, help to advance the field with the best practices that we execute with our partners here in Michigan.
Thank you. Are there any further questions? Okay, I really appreciate you coming in today. A lot of good and useful information. We know it's not always fun to have to come in and sit in the hot seat and take questions that you don't know what they're going to be ahead of time. So I appreciate it, and thank you for your time.
Thank you, and thank you all, committee members.
So at this time, Representative McDonald moves to excuse absent members. There being no objection, the motion prevails by unanimous consent. There being no further business before the committee will stand adjourned. What's that?